Hey guys, this is Dr. Mahajan from Mahajan Medical Center. I'm a board certified internal medicine physician. I'm very excited on our weekly webcast today. We got a great show with the local transplant surgeon and his second patient, first patient with left ventricular assist device. Mr. Pruitt is going to be joining us today, and we're going to be talking to Dr. Caldeira, who started the heart transplant program in Pinellas County, the first of its kind for our side of the bay. And it's very exciting as the patients don't have to go across the bay to get their transplant needs met. So this is super exciting to have him in our community. Dr. Caldeira is very well trained. He is board certified in thoracic surgery. He's trained in Cleveland Clinic and Case Western, and then he spent some time doing lung transplant and heart transplant at Tampa General Hospital. And it was very exciting for him to start the program at HCA Largo Medical Center about a year and a half ago. And that gives our local community access to a fantastic program to get their cardiac transplant needs met. As you know, the cardiac transplant, there are about 4,000 cardiac transplant done worldwide. Out of that, in U.S., we do 2,000 cardiac transplants successfully. The first cardiac transplant or heart human transplant, as you guys know, was done in 1967 by Dr. Christian Bernard, and that was a landmark treatment modality available, started getting available to patients with end-stage heart failure. His patient was a 53-year-old patient, and Louis Wyshansky was his name. Interestingly, my connection with that as I was researching this topic, it was done on December 3rd, 1967, and I was born on that day as well. So to me, that was an amazing coincidence, and that pushed me to do this program with Dr. Caldeira and Mr. Pruitt. So let's get Dr. Caldeira on the show and see what he has to offer to our audience and educate our audience about the cardiac transplant. And we got Mr. Pruitt on the program as well. So just let's get a little bit repositioned because we got a split screen. Hi guys, can you hear me okay?
Yeah, absolutely.
Yes, let's get this screen cleaned up. Here we go. All right, so we got Dr. Caldeira in the middle and Mr. Pruitt with the green background in the back. So tell us about yourself, Dr. Caldeira. How did you get interested in the transplant surgery? Tell us about your background, please.
Good afternoon, Dr. Mahajan. Thank you very much for the invitation to participate in your program. Well, it's a long story. My initial interest was really to be a pilot.
Wow.
And I was unable to get in the Brazilian Air Force, where I'm a Brazilian, couldn't get into the Air Force because I was already wearing correction, eyeglasses. So from there on, I was kind of lost what to do. And that by influence of friends, getting to medical school. Because a lot of friends, in my, neighborhood was physicians or related to physicians. First year of medical school, got in love with cardiac physiology and cardiac anatomy. And from just the beginning, I decided that putting both together was cardiac surgery. And then towards the end of medical school, which is 6 years in Brazil, I was already volunteering in the cardiac post-operative care unit. And I learned that the student was allowed to go abroad I wrote a bunch of letters and ended up accepting, I ended up getting a letter from a chief resident in Stanford who had just graduated and was now in Hawaii. And he said if I wanted to come to Hawaii to do a rotation in his service, I would be more than welcome. So in my last year of medical school, I ended up going to Hawaii for 3 months and spent 3 months with Dr. Carlos Moreno Cabral. And he was a cardiac transplant surgeon training in Stanford and ended up opening the cardiac transplant in Hawaii. And so that was my initial, interest in cardiac transplant. Ended up finishing and going to Hawaii to do my general surgical training. And I spent another 6 years, training with him over there.
Okay, great. Let's get Mr. Pruitt in the conversation. Mr. Pruitt, tell us about yourself. Did you grow up in Florida? What's your backstory, sir?
I've lived in Florida most of my life. Because I was a commercial fisherman for 30 years and just pretty much lived on the water. And all of a sudden, a couple years ago, I started getting short of breath and I contracted a viral infection in my heart. It got enlarged 3 times its size, and they wanted me just to wait to see how much it would go down on its own, and it only went a certain percent, and then I had to go back to the hospital because of my breathing. And then that's when I met Dr. Caldeira, and actually my primary care physician kind of had already told my wife and daughter that pretty much that was all they could do, and I could go home until they couldn't take care of me no more, and basically let me die. And my wife and daughter were on their way to the chapel at Largo Med, and Dr. Caldeira's PA, Missy, stopped them in the hallway and said there was someone that they might want to meet. And he met them, and from the first time my wife and daughter met him, he said he had saved my life. And here I am 2-3 years later. He put the first LVAD in me May 14th of last year, the very first one in Pinellas County's history. And April 18th of this year, he put a new heart in me. So I'm on my 3rd month as of the 18th, and according to Dr. Boyle, his partner, that I call him the maintenance heart doctor, Dr. Caldeira is the parts changer, and he says everything's going great and life's going on. So I'm looking forward to it every day. The dirt's under my feet and not on my face. It's a good day, and I thank him for that.
That's fantastic. That's a great story, Greg. Tell us a little bit more about your symptom. You said short of breath. Did you have leg swelling? Were you fatigued? What was your symptoms?
No, basically it was just short of breath because I was in Largo Med a year prior to that and had where you get your throat stretched, a hiatal hernia thing or whatever it's called, and they had a picture of my heart from when I was in there a year ago. And then when I went back for the shortness of breath, they did another test, and it showed that basically my heart went all the way across my rib cage and was putting pressure against my lungs, and so I couldn't breathe. And other than that, I wasn't lightheaded or faint or nothing. Appetite was normal. It just got to where I couldn't breathe. And
Dr. Caldeira, is that typical patients?
Yeah. Again, typical patient with heart failure present with shortness of breath and congestion. It depends what is the primary pathology. On Greg's case, as he mentioned, was a viral cardiomyopathy that affected the left and the right side of the heart. Some patients have, predominant right side failure. Other patients have predominant left side failure. Greg had both sides, but the left side was the worst one, causing a lot of congestion of his lungs.
Other than congestive heart failure, cardiomyopathy, coronary artery disease, what are the other indications or end-stage heart failure? How do you see it evolving in the community? What are the common
Well,
causes?
the number one is really, ischemic cardiomyopathy caused by coronary artery disease. The second one comes viral cardiomyopathy, like Greg had. But we also see, postpartum cardiomyopathy. We also see hypertrophic cardiomyopathy. 55% of the time that you have a failing heart is because of the heart is unable to pump enough because of damage to the heart muscle. But if you have a heart that's very stiff as well, a heart that has fibrosis, a heart has a muscle that does not relax, what we call diastolic heart failure, also is one of the major cause for end-stage cardiomyopathy.
Now, once the patient has reached that point and, they have to, get, let's say, tested and they are candidate, what are the indications and contraindication for cardiac transplants?
So we follow those patients with end-stage heart failure, and we try to get them to see a heart failure specialist very early. There are several phases of heart failure, what we call New York Heart Association class 1 through 4. Part one is which patient is really asymptomatic but has high risk factors. And then class 2, we start to have some changes, in symptoms and starting to have deterioration of the overall function of the heart, until you get to class 4, in which patients are symptomatic at rest. That's where Greg was, right? He was unable to carry on any activity without any symptoms. So we follow those patients and we optimize them with medications initially, just pills. We do some special pacemakers that we put on them if there is an indication. We put a defibrillator because they are very high risk of having arrhythmias, with the weak heart. But it got into a point in which medications by pills do not work anymore. That's when we say it's time to evaluate for what we call advanced therapies of heart failure. We do this when we believe that the chance of a patient dying within 1 year, is very high, more than 50%. When we got to that point, we then say, let's measure the pressures inside the heart. And if the amount that the heart is pumping is too low, then we start them with what we call inotropic support. That means going home with medications through the veins in order to maintain that heart strong.
Let me stop you here because I know Greg said he had that inotropic support. Tell us your experience, Greg, before you got into the transplant list. Walk us through what were different things and how was your experience?
Well, when I first met Dr. Caldeira, my ejection fraction for my heart was 4%.
Wow.
So a lot of people couldn't understand how I could walk and not pass out and things, but for some reason I could do that. And he basically put me on this medicine. It was like an IV you would get in the hospital, and we had to change it out every day at home. They supplied us with this medicine that would come in the mail, and we keep it refrigerated, and we would change out a little miniature IV bag every 24 hours. And this machine, you change the batteries, and I was kept alive with that for 3, 4, 5 months. I don't know, until Largo Med HCA got approved for him for Dr. Caldeira to do the artificial.
How did you feel, Greg? How did you feel after starting the medication? Did you feel better with the medications from the vein?
Yeah, my breathing got better. It was like a miracle drug to me. It's like, well, maybe I don't need to have an artificial heart. But he said, yes, exactly. Because of the shape of your heart's in pretty bad shape. This is to carry us over, and it carried me over, and then the rest.
Let me ask you here, Dr. Caldeira, let's introduce the concept to the community about left ventricular assist device. It used to be, just a bridge procedure, but, with the new technological advancement, it looks like, you can make it last as long as cardiac transplant patient live, So tell us more about, I know you're expert in that.
Yeah, so number one, I want to thank Greg for trusting me, right? And trusting his health into me at that point, because a lot of the patients, when they start the intravenous inotrope, they feel a lot better, a lot better. And a lot of times they say exactly what Greg just said. Why do I need a pump? Why do I need a heart transplant if this medication is working so well, right? And the reality is that the studies have shown that this medication makes the heart pump stronger and better. Patients feel better, but it's just a patch. That medication, patients that goes into that intravenous inotropic support, only 50% of them are alive after 1 year. After 2 years, 90% are not alive anymore. They have died. So based on that, we developed this new machine that was studied comparing medications through the vein versus a machine. And it demonstrated to us that patients that go on the machine, they live longer and a better quality of life than patients who go on the medications through the veins. Well, after the first studies demonstrated that, we start to ask our questions. Can we leave the patients on the machine for a long period of time? Not 1 or 2 years until they get a transplant, but can we leave them to live with that machine forever on patients who are not candidate for transplant? And what it demonstrated to us, those studies comparing patients who are not candidate for transplant, it was that, the patients that go on the machine, they survive more than 5 years in 75% of the time. So that means that before we had the patients dying of pills, 50% of them dying within 1 year. Then they go in the intravenous support and they survive better, but their survival rate is not much longer. And now with the machine, they survive longer and at least 10 times longer than the patients that are going on the intravenous and with a better quality of life. So that's what Greg had. I think Greg had the machine close to a year before we pulled the plug and decided to transplant him.
So now, with the left ventricular assist device, you got to think about the limitation too. You got to think about the power source. You got to think about batteries, hemorrhage, infections. So it comes with its own host of, risk too. But do you see in near future with the 3,000 to 4,000 patients in U.S. waiting for cardiac transplant, it to replace if the technology keep improving, just the cardiac transplant with the less availability of the heart?
Yeah, so I'm getting old, right? When I started this field, these machines were huge machines, very noisy machines, or a displacement pump with a push plate. Nowadays, they are very small, they're centrifugal, they have way less complications and noise, and the battery lasts much longer than what it should be, right? But it's not comparable to a heart transplant. No question that the best therapy for heart failure is a heart transplant. But we're getting closer because the survival rate of someone with a heart transplant is approximately 14 to 15 years. Okay? So we are getting close on those new machines to get a survival rate similar to that. However, like you mentioned, we have a drive line that we call that brings the power to a controller into batteries that passes through the abdominal wall and introduce the risk of infection, right? Patient needs to be on blood thinners to prevent stroke and all those things. So there are complications, but technology is evolving. We are developing new machines and machines that do not have transcutaneous energy transfer, in which there is only batteries inside and nothing outside passing through the skin.
So, if I read my data correct, but 1 year survival rate currently is 88% on the post-cardiac transplant, and 5 year is 75%. What was the survival rates when you started your training, and where we've been with all the advancement of immunotherapy and inotropes and left ventricular assist? So walk us through the journey.
Yeah, so the ventricular assist device has been an incredible, story, right? Like I said, we started with the large machine, push plate machines, and we compared them initially with inotropes and demonstrated 3 times better survival. Then that machine was compared with non-inotropic support with a new machine called HeartMate 2 that had no displacement. It was like a turbine. Now the survival rate went way better. Now, as I said, 75% survival rate up to 3 years. And from there on, continue to improve now with the HeartMate 3 and the hardware, which are centrifugal pumps. And those centrifugal pumps are getting very close to the 75% 5-year survival rate. So this is on the machine side. On the immunosuppression side, we had a huge improvement a decade ago. We continue to learn, we continue to develop new drugs, and the improvement now is a slow improvement. You should have around 12 years was the half-life, meaning 50% survival. Now we are up to 14 and a half, the half-life of a heart transplant.
Great.
So we are learning a lot who benefits more from those transplants.
Let me get Greg in this discussion now. Greg, tell me about when you got, I know you get beepers, correct? So that way you are available when you get on the waiting list. So tell us about your experience when you got the call from Largo Medical Center that you have a heart available. Tell us, you were telling me that story. That was very interesting.
Actually, I was sleeping and I got a call from Dr. Boyle, I call him the maintenance heart doctor for Dr. Caldeira. And he's the one that checks the oil and keeps the medicines up and makes the adjustments and the tweaks that they have to make as you go along and you progress. And your ejection fracture, your body accepting the heart gets better and better. And my 3-month anniversary was the 18th, 4 days ago. And my last 2 visits, which has been a total of a month, my ejection fracture for the new heart was at 0. So that meant that my body is totally accepting the new heart.
So
the LVAD, when he put that in, the recovery, I mean, the very next day after they did the surgery, the day before, the next day, I was up walking around the hallway. It's like, boom, you got instant life, breathing, you feel like a brand new person. It's like instantly. I mean, naturally the heart transplant's a little bit tougher, but still you're alive and you're going for the long term. We were kind of wanting to go maybe a little bit longer, but the coronavirus, COVID-19, it's a bad thing, but actually in a way it was God looking down on me, and a lot of people were afraid to have a heart transplant because of that. And I trust my doctors, Dr. Caldeira and Boyle, 1,000%. And I finally asked Dr. Caldeira the day, Saturday or Sunday when I come in there, after I agreed to do it. I said, Doc, would you do it if it was you? And he said, yes. I said, then let's go. And the rest is history.
So, the average survival after someone's heart is harvested to be viable is 4 hours, right? So walk us through the journey, how the magic happened, Dr. Caldeira.
Wow. So basically, when we decided that someone is in need for a transplant, we go through this big evaluation process, and it's a big funnel that we need to select the right patient who will care for that gift of life. And we put the patient on the waiting list. The patient will be waiting, and as a Greg, I was expecting Greg to wait for a very long period of time because he was not very sick with the machine. But we start to get offers. Whenever there is someone who dies and is donating their organ, there is a network of organ sharing called UNOS that basically contact the local OPO, and they develop a list of priority, the sickest ones on the top of the list, and then coming down, and then how far away those recipients are from the donor. And then they generate a list, and they start to call everybody on the list from the top to bottom. And we evaluate the donor heart, and we say yes or no. And we put a provisional yes, for example, and waiting for more tests to be done on the donor. And then we have half an hour to say, yes, it's mine, or no, I'm going to pass on this heart, I'm going to wait for a better one. When it came to us, we put a provisional yes for Greg, and the ones on top, decide to decline on their heart for one way or the other, one reason or the other, and Greg became primary. So at that point, I called Greg and I discussed with him, or Dr. Boyle called, and said, hey, we have a heart for you. It's a perfect heart. It's a good match. There are some challenges that we need to face, but we are up to the task to get it done. So that's when Greg came into the hospital. We had another patient who was a backup if he would say no. And Greg decided to move forward. So at that point, we sent a team to the donor hospital, and Greg stays in our hospital here. That team goes over there and coordinates all the organ transplants that's happening, because usually the donor donates several organs at the same time. So they coordinate to arrive at one time. They open the donor, they evaluate the heart, they look at the heart, they look on the tests, and then they make a decision together with me if it's a good heart for Greg or not. And if it is a good heart, then Greg goes to the operating room. We start the operation on our side over here as the donor is being prepared for harvesting of the organs. So it has to be very well coordinated. Those hearts can be coming from far away. And sometimes we travel 2-3 hours. We have to have a very smooth transition between removing the heart from the donor and arriving the heart at our hospital when the patient, Greg, is ready, open, and everything is ready for the implant. Because Greg had a scar tissue because of the prior surgery, it was kind of a challenge operation, right? To open and prepare and get things ready. But again, that's what we do every time. And Greg's heart was within the 4 hours, and they just turned on right away and was able to separate him from the heart-lung machine and did very well.
So let me take you back to your first heart transplant surgery when you did on your own. You know, you're done with your fellowship. They said, "Okay, we trust you. Tell us about your nerves and your experience."
Oh my goodness, it's a nerve-wracking, right? Really nerve-wracking, because that's when your first one, you're really doing now. You went through all this training. Remember, I start telling you there was a pilot, right? That I wanted to be a pilot, and I am nowadays a pilot. So I compare the first heart transplant as the first time I flew by myself on the airplane and I had to land the airplane. Right? There was no way out.
Yeah,
You either do it or you do it, right? And if you do it, better do it.
Not somebody else.
When you do it, better do it right? So we go for a lot of training, a lot of confidence, you know, that you can do it. Your teachers, your proctors who train you are confident they can let you loose, and they're watching you from the beginning. And I think that I got a very good training from the beginning. So I really felt that I was ready, you know, to do my first one.
Great. Let me ask you a silly question. You know, a lot of people say, you know, if you get a female heart, you know, that's not good. If it's a male to male, that's better. Female to female, that's better. Is there some scientific thinking, like the size of the heart or hormonal, you know, how they've been, or there is just a, you know, you get a good heart, you get a good heart?
Dr. Caldeira told me, you know, it didn't matter whether it was male or female, that I also had a broader range to get a heart from because of my size. I could get it from a teenager because of my size. I could get it from a woman or from a male. Any one of the three to work. If I was, say, a larger man, 275, 300 pounds, then it's a lot harder to get a heart for somebody that size. And he also informed me that we could go up in the size of the heart a little bit, you know. So I had a lot of things in my favor as far as getting the heart.
Greg, I'm proud. You listen to me, huh?
Yeah.
That is
I'm
good.
alive because of you. I wouldn't be taking you fishing if I didn't.
So I heard Dr. Caldeira didn't tell you got a female heart and now you're more emotional, correct?
No. But I have been emotional around him. Though.
But Greg is very right. So it
But
makes
if
no
it was
difference
Spanish, I
between.
haven't learned no Spanish.
There is no difference between male and female, although the female heart's a little smaller. So we need to be careful with the pulmonary pressures on the recipient. If the patient does have high pulmonary pressures because of chronic congestion, then we try to select a bigger heart or a male heart to be able to pump against that pulmonary pressures that the new heart is not used to. In Greg's case, his pulmonary pressure was elevated initially, but because of the chronic decompression that he got with the ventricular assist device, his PA pressures came down nicely, and we were able to get a small female heart for Greg. That's why he's like that.
All right, all right. So tell me, is it? Tell me if it's fact or fiction that I heard that there's 6% people change their personality post cardiac transplant. Is it the new heart bringing some cellular level memory from the previous person, or is it the heart lung machine, or is it the immunotherapy, or what's your take on that?
Greg, that question's for you.
Oh, I don't see no take. Before my wife says I get a little grumpy, but I was grumpy before, I don't see no change. Actually, I joke with the girls on Dr. Caldeira's team that, hey, every day the dirt's under my feet and not on my face. And you cherish things more. It's like my grandsons. We're going to Fort Myers this weekend for a baseball tournament because he's a very good ball player, and already as a sophomore had colleges starting to send letters. So to me, that I can go and watch that's like the Visa card commercial. That's priceless. I have a 5-year-old grandson, and I want to see him grow up. So I'm grateful, and anytime I can help him or someone like you do something like this, I'm all for it.
So, Dr. Mohaj, I think
I
that's
also help the patients at the hospital. I've probably talked to 10, 12 patients that were on the fence about the LVAD, and someone tends to, I know I would, if you talk to someone that's experienced something and they see me carrying in an LVAD and explaining it to them, if they were maybe on the fence about doing it or not doing it, I think it helps persuade them because I've lived it. It's not somebody just talking about it who hasn't lived it. So anytime I can help the doc out, I will.
So I don't think there is any science behind personality change. Although I must say, people like Greg is really incredible because they give to the community back the present, the gift that he has received, right? And it's very important to Greg do what he's doing right now to increase the awareness of the population that a lot of times is not enough life. There is more that we can do. We get a lot of patients like Greg that we get out of hospice, that we get out of, hospital beds that they are end of life. Not because there is no treatment, because there is lack of knowledge that there is treatment for this end-stage heart failure.
Yes, so we got a comment from, let's see, let me pull that up. Brandy's saying, you look a little bit grumpy, Greg. So, people are noticing that post-transplant, there is changes. We got a
horrible patient. And that's one thing that when you get an LVAD, that the Dr. Caldeira's team is very good about. The girls, the LVAD team, the coordinators, is the training that they have to teach your loved ones before you leave the hospital on the proper taking care of, where your drive line goes in your belly, and proper, cleaning and the sterilization that they have to go through. It's almost just like they were going in the OR with wearing the gown, the mask, the gloves, and they also had to take a 50-question test and perform 2 or 3 bandage changes on me, so they were assured that I could properly be taken care of to minimize my infection. And knock on wood, somewhere here, we never had not one problem with infection at all. Once in a while, I get used to kind of having an LVAD, and I would get maybe a little bit careless, and my drive line would maybe catch on something. But you have plastic anchors that you put down, to keep that from pulling it, out from inside your body. And it might pop one of the anchors off or something like that. But other than that, if I wouldn't have got a heart for 10 years, I wouldn't have got a heart for 10 years.
Hey, Greg, let me show you something. I didn't realize there is a connection. Brandy said that's your dad. I didn't realize that she was someone saying grumpy. She knew you, but she knew you well.
Yeah, that's my baby girl. Actually, it's funny you say this. My daughter Brandy was a hairstylist just right across from your office at Salon West, making
wow.
a very good living, $75,000 a year. And because of what's happened to me and the education that she's gotten from this, she's already completed 1/4 of her nursing school and has quit doing hair. And she's going to get her nurse's degree, and then naturally she wants to work for Dr. Caldeira.
So let's talk a little bit more about the surgery itself. So it lasts 4 to 6 hours or more, depending on, as you said, if they have scarring or they have blood thinners or they have LVAD before, so it takes longer. And then maybe a week in the ICU or less, depending on how they do. Or
No, the operation takes around, it depends. If the operation is done in a fresh chest that have never had surgery, it's really a simple operation. It takes around 2 to 3 hours to do it. The technical part of the operation. And then, of course, the heart has to perform. If it's an operation like Greg had, in which had a ventricular device before, it's a little longer. And probably Greg's operation took around 4 or 5 hours or so. The post-op care, it's also very variable. I did a transplant last Friday, and the patient is going home tomorrow.
Wow.
So it's really 1 week in the hospital. I think Greg was in the hospital probably a little longer than that, probably 10 days or so, Greg. I don't remember.
8 days.
50, 8 days. Yeah. So again, thanks God, we have had very good results. The post-operative care really is testimony of the nursing care at Largo, that has stepped in and doing the fantastic job to help me out caring for those patients post-op. But
tell us about the whole team. How many players are involved, and what's their role, so people have a sense.
It's grown since he started. I know that.
Yeah, and it's a lot of people, I tell you that.
Yeah.
So on the pre-op, again, like Greg said, you have nurses who are specialized on those machines and on a transplant that we call heart failure coordinators. And they're a babysitter for Greg, before and after the transplant to make sure he's taking the medications, following the appointments, setting up all the tests that needs to be done and all those things. So really, they are a fundamental part of the team. We have 2 heart failure cardiologists that manage and help with the medications and caring. I'm the surgeon. I just hired a partner that's hopefully is going to start next week to help me out. We have a team of anesthesiologists dedicated to heart surgery. In the operating room, we have nurses, scrub nurses, first assistants, anesthesiologists, CRNAs, all of those working together in the operating room. Finishing the operation, going to the ICU, critical care nurses, respiratory therapists, physicians, critical care physicians. So if we put everybody together, it's a big team that needs to come, learn, develop these skills, and basically caring for him from the beginning to the end. But I must say one thing, Doctor, that although it's important, the operation and getting Greg home, the most important person to keep Greg alive for the next 10 to 15 years is his dedication to his own care and his family. So having said that, his daughter is going to nursing school with all this experience. It really speaks to the dedication that his family has to get him through not only the operation, but the long-term care that he needs to stay alive.
So let's bring in COVID into the play. Is it change your, in terms of your number of cases you're doing? As Greg was saying, people are hesitant, and they should be, if they can, if they have choice, if they're doing well on left ventricular assist device. What's your take with the COVID? Has it changed, or I'm pretty sure people have to be more careful, like Greg, post immunotherapy now, immunosuppression therapy, in terms of not getting exposed to public places and things like that. So tell us, how's the COVID changing your, practice?
It changed a lot, right? Initially, when March came, we decided that we would stop doing elective surgeries. So we're doing just emergencies. At that time, we talked to the infectious disease specialist at Largo, we talked to the administration, and we said, listen, this is an emergency. This is not an elective procedure, right? Greg can die at any time of his heart failure. So we decided that we would consider heart transplant as an emergency. At that point, we said, are we safe to move forward with the transplant? And we put our heads together. He said, yes, we can do it. We will be safe. We will separate them from the others. We're going to follow all the criteria developed to maintain a safe environment for Greg, and we think we should do it. A lot of transplants were not done in the country because of the COVID. So having said that, I think that we also we are kind of an aggressive program in which now we are taking patients or donors that have hepatitis C, for example, or donors that comes from far away, older donors. The heart is not a perfect heart, but we believe that we'll get better with, time. So with this aggressiveness, we have had more availability of donors to our patients who are on the list right now. So since we started our program back exactly in March, right? And April was when we really listed our first patients. And since then we have done 5 transplants, which is an incredible volume for a small program. And not only that, I was expecting Greg to be waiting for a heart for 9 months, a year. And he waited for a heart for a whole 2 days, 1 week. Right?
Wow.
And got a heart. And our waiting list has been extremely short.
Because, I was looking at the average, national average is what, 180 days, 190 days, somewhere around that?
Exactly. And we're getting an average.
From LVAD to new heart, 11 months.
Yeah. But from the day we listed you for transplant, Greg, was 1 week.
Oh, yeah.
And we had a heart.
I wasn't expecting the call. Yeah.
Exactly. So our waiting list has been very short, and I believe it's partly related to the COVID. We at Largo are really doing our best to keep patients safe. We have transplanted 5, patients, and all of them have done extremely well without any infection whatsoever.
Okay, great. Tell us, you said you were doing lung transplant when we were chatting before this interview at Tampa Journal, and you're hoping to get that started at Largo Med next year. So walk us through how is that different or similar to the heart transplant?
Oh, it's quite different, right? Again, number one, the pathology is a different pathology right now.
Sure.
We're dealing a lot with emphysema and pulmonary fibrosis, cystic fibrosis. Those are the main pathologies that, cause a lung to fail. The procedure itself, the operation itself is different because most of the time we do without stopping the heart, just, opening the chest and doing one transplant versus the other. The post-operative care is challenging. It really requires a special pulmonologist. The risk of infection is much higher. The organ is much more sensitive than the heart, as far as, although it lasts a little longer, 6 hours in the heart, when a complication happens from pneumonia, trauma, it's a major complication usually. So we are ready. We are ready to start, the lung transplant program in Largo. I just waiting for the heart to take off, stabilize, get our Medicare approval, and after we pass, the initiation of the heart transplant program, then I'm going to be ready to, tackle the next challenge.
How many cases you need to do to get CMS to approve?
So we have to do 10 heart transplants
10.
before we get approved by CMS.
So you're already halfway there.
We're halfway there, and we have one patient listed right now, but we have 7 more on their pipeline to be listed. So
Okay.
I'm very confident by the end of the year we'll get it.
Let's get one more comment, and I think that will be a good segue. So here is Carrie Green. She's saying in 1990s she worked in Atlanta, and the LVADs were huge, and you just said they became smaller. Let's talk about future of patient with end-stage heart failure. There is, LVAD. We talked about that. That could be a, long-term, as the technology is getting and they're getting miniaturized and the battery lives are getting higher. So that could be a prospect if they're not getting the heart, at least, if they want to opt in that direction. So that's one. But how about gene therapy? How about, stem cell therapy? How about, other animal like pig? What's happening in future? I know he's pushing the boundaries with, it started, we getting to 14, 15 years of life expectancy. But still, as Greg was saying, he was doing C research and it costs 1.3 million to get a heart transplant, and you're getting 14, 15 years, which is, fantastic. He can go to his grandson's baseball. You can't put a price on that. But where you see the future?
Well, let me do a few things. Number one, he's very right saying in the 1990s, the machines were huge and the patient couldn't be discharged, had to be pushed around. And with the technology evolving, most of the patients are home nowadays, like Greg, without having to do them in. So gene therapy and other therapies have been evolving, have been getting better, but they are not prime time yet. I do a lot of transplant on patients who have had gene therapy. It's not approved in the United States. They have to go abroad in order to get it. And a lot of times those patients get better for a short period of time and to deteriorate later on. Future holds something better. There is no question that we will get there, but it's not prime time yet. As far as the price of the transplant, is very expensive, right? It's a $1.3 million, the total care of that patient. The cost from beginning to end, hospitalization and everything else. However, it's a lot cheaper than to maintain someone on heart failure medications, readmissions to the hospital every 3 months. You can ask Greg how many times he was admitted to the hospital the year before he got a ventricular device.
Okay, Greg, how many times you are admitted?
4 or 5 times.
Wow.
4 or 5 times to the hospital.
And
So if you
what he was saying about the medicine today, when they took my biopsy today, which when you get a transplant, they take a biopsy of your new heart once a week for the first month, and then for the next 2 months they do it every other week, and then after that they do it once a month. Well, one of the medicines that I was on, Dr. Boyle said today that just finish up the prescription that you have at home, and I had just picked up a new one, and that one prescription alone, 30 pills, was $2,000.
Wow.
So fortunately, I hadn't broke the seal, and I took it back to the pharmacy, and they took it back because I didn't want it to go to waste. Even though the Social Security and Medicare, it didn't cost me nothing. I just couldn't see wasting $2,000 for 30 pills.
Yeah. So it's very, very expensive, the maintenance. But as I said, when you compare the whole treatment of heart failure, it's really a fraction of the cost. And not only that, a lot of the patients become productive again, go back to work full time.
I just got a letter today. I just got a letter today from Dr. Boyle saying that I could go back to work light duty, clerical, government reports, things like that. I just got that.
Nice.
Fantastic.
3 months and 3 days after I was laying on Dr. Caldeira's table with my chest wide open.
That's amazing.
Yes, it is.
Yeah.
And I'm grateful.
You didn't talk about the I know the pig heart has been used in baboon. Is that something you see a viable thing with the organ availability being scarce?
Yeah, xenotherapy is still, again, not there yet. There is a lot that we need to learn in order to trickle someone's body not to recognize that the heart is not yours or it's coming from another animal. I want to say something here, since you mentioned, because we do approximately 2,000, 2,500 hearts in the United States every year. But there are 40,000 patients who today are in need for heart transplant in the United States. So it's a very small population that get lucky enough to pass through this very tight funnel that we select patients, because most of them will be dying of heart failure without the opportunity to get a heart transplant. So that's when really ventricular device come into play. That's where we're hoping one day xenotherapy with baboon animals, transplant of animals will help us, or gene therapy. But today, we have a lot of people that end up dying of heart failure because of lack of availability of organs.
That's a great point. Let's bring another comment here. We got Alicia Hader saying, we are lucky to have Dr. Caldeira at Largo Med. I second that thought. Not only, having a transplant surgeon in the, community hospital give access to the transplant and reduces the expense of going to far off places and the stress to the family going back and forth, that get reduced because you got a center of excellence building here. But I think, I go to Largo Med for the last 20, 25 years. I see the morale of the surgeons, the cardiothoracic surgeons goes up too, that they can take a difficult case. So other than cardiac transplants, I know that you do 5 since March. What else you do in the hospital, Dr. Caldeira, and offer the expertise you gained?
So again, my primary interest is cardiac operations. So any operation in the heart, valves, coronaries, aneurysms, machines like Greg had, that's my primary. Whatever operation is needed on the heart, that's my expertise. I get a lot of referrals from other surgeons because, we have the availability to take very difficult cases and do things that the other surgeons cannot do it or are afraid to do it. Emergencies like dissections, aneurysms, and things like that, it's also very common for me to do it. Nowadays, to be very honest, with the COVID, we have had an incredible opportunity to support patients who are on respiratory failure. For you to have an idea, today I was just calling my partners around the state. We have at Tampa General today, I think 6 patients on ECMO, artificial lung machines. In Orlando, I just called one of my partners over there, and he tells me they have 8 patients on ECMO. And the other one is here, and we have today in the ICU 11 patients on artificial lung machines that are being supported and being alive because of the new program that we are developing to put those patients on artificial lung machines for COVID and for other respiratory problems. So again, I must say that we're very proud of what we have done at Largo the last year and a half, and bringing a community hospital from doing just bread and butter case to do cases that are unique, difficult, and with good results. I think that, it really speaks to the administration of HCA and Largo Medical Center to invest in the community.
Yeah, I was reading, I think the chief medical officer, Dr. Feynman, was talking to the Pinellas County other day, and he was talking about, how, they should continue the emergency order because, in the West Coast at CA, there are like 13 cases on ECMO, and typically he said we get 3. So, that's huge with the COVID-19, and that's fantastic. So, for people who don't know about ECMO, give us a little bit primer to our community. What is ECMO? How is it different than the ventilator?
So ECMO is an extracorporeal membrane oxygenator. So when the patient is in need for the lung cannot work anymore because of a pneumonia related to COVID or any other pathology, we have already the patient on the machine, on the ventilator, pushing air into the patient's lung, but that's not enough. What we do is to put very large bore cannulas in big vessels on the groin, on the neck. We remove the blood from the body, we circulate on the machine and oxygenate the blood, and we give the blood back to the patient. It's that continuous flow passing through this oxygenator and inserting the blood into the patient. And with that, we're able to give time for the antibiotics to work or for the viral infection to be treated and the lung to heal before we remove it. Our program over here has been very aggressive. Like, finish over here, I'm going to be going to Fort Myers tonight to get a 41-year-old who is COVID positive and bring it back to the hospital because they don't have the expertise over there to do it. So we are really, right now, quite honest again. I spoke to my chief medical officer today because we don't have more machines, we don't have more nurses, we don't have more ICU beds to care for those patients because we are completely full. Wow. And we are asking for the support from the state, from the government's office, in order to get more machines, more ICUs, more nurses, because this COVID pandemic is real. It's real, and a lot of young people dying.
And, to that point, I know cardiac transplant is sexy and fancy and all that, but I think, COVID-19 has touched so many different lives in different ways. A lot of healthcare workers are, getting hospitalized and sicker. And so I think everyone needs to chip in and do their bit and wear the mask. And as you said, it's real. And it's not political that you need to wear mask. I wear mask for you, you wear mask for me, and we wear mask for each other. It's not that, I'm taking your right away. You wear your, pant and shirt if the restaurant does not serve you. How different is that? Or if you don't, not allowed to smoke, you don't smoke. It's not taking your right away because it's not good for other people to inhale your smoke. So I think mask is again and again been shown to flatten the curve. So I appreciate you bringing that point up. And, at a certain point, if I have a friend in New York and, I was talking to him the other day and he was saying the same point. All the ECMOs are taken when they were in the peak. Right now, thank God, New York is not a hotspot and we've taken over from them. But he was saying that they have to make decisions at the time which are not pretty, that if you're a certain age or you've been on vent for so long or you're in ECMO for so long, and they will pull it out automatically. That's not a situation we want to be in. And if we can make a difference by wearing masks and keeping social distancing, washing hands, that's not too much to ask, because how are you going to be treated? It's not just the COVID. I was talking to the CEO of HCA Largo Med, Adam Rudd, and he was saying, COVID is 20%, the rest is 80%. You're still getting heart attacks, you're still getting strokes, you're still getting pneumonias from nursing homes, which are not COVID. And if you have all the beds full in ICU with COVID, and as you know, the COVID patient lingers in the ICU for weeks once they get sick, once they get the cytokine storm, where are they going to go? So we're going to have deaths from, unfortunately, not having availability or the fatigue of the staff. As you said, ICU nurses, they have to wear the PPE, hold 8 hours, 12-hour shifts. It's exhausting, yeah. And it's day in, day out. It's not that for a month, 2 months, there's no end unless we all work together.
And I must say, we are selecting the operations that we're doing right now because, we don't want to overload the system with elective operations. But sad is that people are not seeking the care that they need coming to the emergency room when they have a major problem because they are afraid of COVID. And I must say that we are doing everything. Largo Medical Center is safe. If you have chest pain, if you have problems, you need to come to the emergency room, because if you avoid coming, by the time you come to the emergency room, it may be too late. The number of admissions for the emergency room has decreased. The number of emergencies that we see have decreased, not because people are not getting sick, but because they are not seeking the help that they need on a period of distress or acute problem.
Greg, I know you're going to sleep. Let me get you in the conversation.
I was looking at a message from Brandy, my daughter.
Okay. Tell us, in terms of your experience, what stands out, what Largo Med and Dr. Caldeira's team done, what single instance or 2-3 instances stand out where they went beyond?
One thing that really stood out in my decision primarily was what I asked him point blank, face to face. If it was his heart and his life, would he do it? Yes, he said yes. But the other big factor is that at Largo Med, you have individual rooms. So, you're not in a room with somebody else. You have your privacy. So there's a lot less chance of the spread. So I felt that was a safe place for me to be with this virus going around, because I am, being I had the LVAD, I was one of the higher risk, like diabetes and things like that. So when they approached me, I said, well, let's do it, because I felt I was safer there, because they have, only one bed to a room. So that's probably one reason they're full. I feel you're safer, and you're not getting something from the person beside you or whatever. So that was another big factor. And I believe that before this program started at Largo Med, I would probably be the first one to tell you that I would have went to Morton Plant. But now that Dr. Caldeira and his team has come there, I'm probably the best advocate that they have for that hospital and HCA, because they are turning that hospital around to where we'll be seeing them on the World Report.
Thank you for coming to the program, Greg. I know you have, been with the ringer in last 3 months, and it's so good to see you walking around without oxygen and without dragging the LVAD. So that's a fantastic success story. We'll give you the whole screen to Dr. Caldeira and give us final thoughts and how we can encourage our community to donate the organs. Let's have a thought on that.
All right. Thank you.
I think that is very important. What I said before, again, the volume of people in need is huge. Is the best treatment for heart failure is a heart transplant. And it's your support that really will change and increase the number of patients who have access to this therapy. I encourage you to talk to your loved one. They will be the ones who will make a final decision in case it comes to a point in which donation is an option. A lot of the donors are out there. They want to donate their organs after death, but the loved one does not know, and they will be the one granting your wish in the end. Come to the hospital. We are here for you. We are here to keep you safe. We are here to provide the service that you need in all aspects, and we will be fighting for you from the beginning to the end. So if you have any questions, please reach out to us, and we'll be glad to help.
Thank you, Dr. Caldeira, for your time. I know you're busy, and it's been a fantastic to learn from you, and we are so happy that you are in our community. I know you come from Brazil, and we don't have as populated beaches, but we got pretty beaches here. So hopefully that will keep you in our community for long. And we would love to see the success you brought to the program and rub off on other departments at Largo Med too. So thank you so much.
Thanks, Dr. Mahajan. It was a pleasure to be here.
Yeah, take care. Bye-bye. All right, guys, that was a fantastic input from Dr. Caldeira and Greg about their experience on cardiac transplant. And we are so happy that Dr. Caldeira has such a success with the program so far with 5 successful transplants. So we wish him a lot of luck so he get to a point where he gets up to 10 cases done within a next short period of time, and get the CMS approval as a transplant program where CMS pays for the services. So we wish him a lot of luck, and that will be good for our community too. With that, we come to the last part of our show, and we're going to practice, as I always recommend, to practice the breathing exercises. And we talked about that in the teaser. The breathing exercise I want to introduce today is called 3-part breathing, or Dirga Pranayama. And the breathing exercises helps you improve your lung capacity. It does help you improve your immunity in the upper airway, lower airway, helps you calm down, helps you deal with the anxiety. So the 3-part breathing is very special. Because we are engaging our core muscles, the belly muscles, and then we are activating the muscles of our lower chest, and then all the way up to the collarbone, chest wall muscles, intercostal muscles. So we're engaging all 3 muscles to help us get the deepest breath we can. So this is how it's done. So you put your right hand on your stomach, and then you blow up your stomach by inhalation like a balloon. So blow it up and then breathe out. So you deflate the balloon of your belly, and then do it one more time with me. Then breathe out. Now this exercise is ideally done laying down with your knees bent, but you can do in sitting with your spine upright as well. Again, it's called 3-part breathing, or Dirga Pranayama. So we did the first part, the abdominal muscle part. Now we're going to add the lower chest to the breathing. So when you breathe in, this time breathe in and blow up your abdominal muscle again. Now add a little bit to your lower chest, and then breathe out, stay tall, and breathe out first from your lower chest, and then push the belly button back. So this is 2-part breathing. Now we're going to add the 3rd part. So again, breathe in and blow up your belly muscle like a balloon. And then add the 2nd part to the lower chest. Now add a 3rd part to the area above your collarbone or around your collarbone to lift your heart up. Now stay tall and breathe out through your nose. First to the upper part up here. Now to the 2nd part. And now push the belly back. So now do it smoothly like this. And then breathe out like from the top to bottom, stay tall. So this is called 3-part breathing. And I'm glad you joined us today and practiced the 3-part breathing. We put a link on our podcast or webcast today. Do practice that. And with that, we come to the end of our wonderful podcast. We appreciate and thank Dr. Caldeira, the cardiac transplant surgeon, and Greg Pruitt for sharing their expertise and their experience, and helping our community understand that we have a good transplant program in our backyard to utilize the services. Be kind to yourself, be kind to your fellow friends and human beings, be nice to your neighbors, and to the earth and the biosphere. Ciao!